Hello and welcome everyone to Insights. I'm Nnamdi Odipo.
And I'm Elizabeth Omori. Thank you for joining us.
This week we discuss how negligence, incompetence, and systemic failure have turned places meant to save lives into spaces of daily loss. We're talking medical negligence, and Dr. Chijoke Obalum, former chairman, Medical Advisory Committee, State House Medical Center, will be speaking to the rising cases of avoidable deaths in Nigerian hospitals and the way forward.
We'll also be talking about youth inclusion through skills development, and Silas Adgara, Director General, National Directorate of Employment, will be telling us how the Directorate has been driving this cause for national development.
Whatever the issues are,
the National Assembly is constitutionally empowered to scrutinize,
however complex or intricate.
We have involved all the academia, the members of the academia. We have involved the academies.
Be it government policies or in fact any issue of public concern.
Our job is to help you gain clarity and make sense of it all.
This is not really healthy for our democracy.
There's a lot of aggrievance in terms of who has been in power longest and who becomes the governor of the state.
It's also in the quality of food being consumed.
After all, perception is insight.
And gaining understanding is also getting insight.
Now, let's begin the conversation on medical negligence, a topic I consider difficult, somewhat sensitive, especially for those who have been impacted lately. Yet, I think it's an essential issue we must talk about so that people and even the authorities can take action. It is quite shocking to hear and even see people going to the hospital and then dying from what amounts to preventable mistakes. The sheer number of people and families who have come forward recently to accuse hospitals of negligence, it's something that should keep all of us and every level of government up at night. To help us understand why all of this has been happening, what may have precipitated some of these happenings, and what must be done, we're joined by Dr. Chijoke Obalum, distinguished medical and legal expert, associate professor of orthopedics and traumatology, and former chairman, Medical Advisory Committee, State House Medical Center. Indeed, Dr. Obalum has a strong grasp of medical jurisprudence by virtue of being a lawyer himself, and so his insight would greatly enrich our conversation. Doc, thank you so much for coming on Insight. Good to see you.
Thank you, Odipo, for having me. It's a pleasure.
Good to have you, Doc, on our show. Doc, it will seem like we're experiencing multiple cases of profound breach of trust in terms of patient safety now. Otherwise, how else do one can situation where a patient dies just days after an operation where a scissors was left inside of our body? There are other cases as well. Well, some prominent, some not so prominent cases and complaints of medical negligence. Interestingly, some of these complaints are not made against these are our often overcrowded public hospitals, but even against facilities we would ordinarily assume are sophisticated, high-tech, and even, upgraded, private facilities. Doc, the thing is, over time, we have even seen health practitioners express concern, over these issues. They talk about things like overstretched facilities. They talk about shortage of workforce. They talk about lack of standards and even effective regulations in public hospitals. But my question to you, isn't it a given to have our hospitals, whether public or private, have in place ethics committees, that are on ground? Isn't that a given? And I'm talking about a mandatory, transparent incident reporting unit that reviews whether successful or unsuccessful medical procedures in our hospitals. Do we have that?
Thank you, Odipo, for your detailed and compound question. You compounded so many issues in this question, but I will take them ad seriatim. Firstly, you have to ask the question whether hospitals do have ethics committee. It is standard practice that every hospital should have an ethics committee. It's also a standard practice that every health practitioner, every healthcare worker must have sworn to a code of ethics at induction. I am almost sure that most government hospitals have an ethics committee. I'm not in a position to speak for private hospitals, but many of them do have ethics committee. Having said that, your next question is, do hospitals have a way of reviewing what happens to the patients? Yes, for the government hospitals, I was in Lagos University Teaching Hospital. I was in National Orthopedic Hospital, Ibobi. I am in the State House Medical Center, Abuja. And I know that every hospital has what we call mortality and morbidity review conference that holds weekly or monthly. And this conference is a meeting of all the health workers, and they review the nature of patients that come into the hospital, nature of diseases. They also review the nature of deaths. What caused the death? Was it unavoidable? Was it avoidable? What could you have done better? These are standard practices in most hospitals. At least I know in most public or most government-owned hospitals, there are standard practices. You have the mortality and morbidity review. And it is a review that gives everybody who is managing a patient in that hospital an opportunity to review, in retrospect, patient treatments and patient deaths, and also may bring up issues or patients who had autopsies because we were not sure of what killed them. We need to do autopsies to confirm exactly, to see what we could have done better. So I guess that addresses about ethics, and that addresses about what hospitals can do to make patient management better in the next patient.
Doc, it's sounding to me like these units you just referenced, the ethics and even the review committee, does their review after the fact, especially for in the case of morbidity or fatality, or in the case that someone dies. How about in the case that, or in cases where a procedure is successful? And isn't that what teaching hospitals do as well? The review, now captures out the procedure and the protocols that went into an operation, what a doctor did at a particular time, the time that it was done, how it was conceived, if there were innovations in this. If all of these happened, why then are we still having cases of negligence on our hands, even more, in public-owned hospitals, state-owned hospitals?
I didn't get your question completely because the network was somehow acting up.
Yes,
but I guess what we are trying to say was, what of successful cases? What do we do in such cases? Yes, for successful cases, there's another different meeting where we discuss about successfully managed cases, and we call them clinical meetings. We call them grand rounds. And in these meetings or the grand rounds, we review patients we have managed successfully, surgeries we have done successfully, and then everybody will learn from the success, from the positive outcomes you have from such patients. So clinical meetings, grand rounds are somewhat different from morbidity and mortality conferences or meetings or reviews. And remember, ethics committee is entirely a different thing. It's a committee, it's a standing committee in every hospital. And then you now say, why do we still have these incidents? You see, in every hospital in the world, from the United States to the United Kingdom to Japan to South Africa, patients die every day. Doctors will do their best, but the patient's condition will ultimately determine whether the patient will survive or not survive, whether the patient will do well or not do well. There's no hospital on planet Earth where patients do not die. But what we are trying to say, are they dying of reasons that are unavoidable, or terminal illnesses, terminal cancers? Or are they dying from medical errors, medical negligence, medical malpractice, criminal errors, criminal negligence, or criminal malpractice? When such deaths are ascribed to a wrong management of the patient, that is what is challenging. That is what is worrisome. Just yesterday, some 2 children received immunization in Lagos and then subsequently died. We know about the celebrated case of Chimamanda Adichie. We know the case in Kano where a scissors was forgotten in the abdomen of the patient. So you see, it's not as if these things hadn't been happening before now, but social media is bringing to fore these hitherto incidents that were not exposed. That is one. Two, people are becoming aware. Lawyers are becoming proactive. The patients are becoming aware. So they're beginning to seek attention for any form of errors, negligence, or malpractice. So we are seeing more and more of this. And with time, we are going to see more and more of this. I mean, for sure, we pray that such things don't happen. But we also will wish that when such things happen, they should be brought to the fore and they should be investigated, and we take actions that will mitigate such things happening in the future.
That's why we're here, and that's, in fact, you've just laid everything on the table. Doc, this is the core issue for us. For a fact, and indeed, just like you averred and inferred earlier, people will die every day in the hospitals, outside of the hospitals. Everybody will die. I mean, that's the only thing consistent in life is the change between when you're born and when you die. So we all would go through that phase. But just like, again, you rightly alluded to, we're talking about avoidable deaths. Deaths caused by, negligence, whether by the medical professionals on ground. And, just, you've talked about a number of cases. I'm glad you brought up the case in Kano, the case in the Ojo axis of Lagos, and the case involving Chimamanda, whose baby also died, and she's alleging medical negligence. Doc, I was following up on the reaction of the former NBA president, Olisa Agbakugba SAN, on this whole issue. And he's almost definitive on where he thinks the blame lies. He describes it as a systemic crisis of weak regulation, poor oversight. And, he says, just like you have said now, lack of accountability. Do you think he has hit the head on the, do you think he has hit the nail on the head? Or for you, is it more of a crisis of resource scarcity or a crisis of managerial and regulatory collapse within our existing healthcare sector or system?
Thank you for your question. Olisa Agbakugba's son is a distinguished legal luminary. Is somebody I respect a lot. Is somebody I admire a lot. And I can tell you that what he identified, all those issues he identified, from systemic failure to poor accountability, are really part of the problem. They are a major part of the problem. However, there are other issues. We can't run away from them. And I can identify some of them for you. And I will even repeat the ones he mentioned. We have systemic challenges in our system. We have poor accountability. We have weak regulation. we have an ineffective enforcement mechanisms of our laws. This is resource gaps. And manpower challenges is just one arm of the resource gaps. The equipment in our hospitals remain not world class, to say the least. Only very few hospitals in Nigeria boast of equipment that can be said to be world class. Don't take away something from Nigerian doctors. Nigerian doctors remain one of the best trained doctors in the world, if not the very best. But having said that, we must guard our loins because, like I said some days ago, some private universities are diluting the quality of our doctors that are being trained. And having identified weak enforcement, I must give a lot of kudos to Professor Fatima Kiari, the current registrar and CEO of the Medical and Dental Council of Nigeria. She's bringing new dimensions to enforcement of the Medical and Dental Practitioners Act and the Code of Medical Ethics for medical practitioners in Nigeria. But remember that medical practitioners are just one of the several groups of healthcare professionals in the hospital. We have pharmacists, we have nurses, we have radiographers, we have physiotherapists, we have medical lab scientists, and several others, medical health information, medical records. They are all part of the system. And we are working together to ensure that the patient gets the best possible care. So the works of Professor Fatima Kiari for medical practitioners should be extended to other professional regulatory bodies in Nigeria for us to get the optimum care for the Nigerian patient.
You know, Doc, I'm glad you brought up the issue of quality assurance, especially in the way and manner that our doctors are certified. And I was quite intrigued when you earlier on referenced how some private universities may be diluting this quality process, but then how the medical and dental association has taken up the task of ensuring quality. I without even getting the data, because I tried to check if I could get data, incident data on Nigeria, when this whole issue started to come up, but I couldn't lay my hands on any. But even at that, it's clear enough that there are relatively lower rates of litigations on medical negligence in Nigeria. Of course, when you compare, that to situations in developed countries like the United States and Britain. This is one of your areas, I should say. I mean, this is legal medical jurisprudence. So the question is, Doc, if we allow this seeming anyhowness that we are seeing right now in our system, to linger and fester without accountability, what happens? What happens? You yourself, you've just mentioned some legal frameworks and institutional structures, overseeing medical practice in Nigeria when you reference the association and the act. But how do these provisions, these institutions, how do they proactively and even retroactively, sanctify medical practice in Nigeria? Is that in place? Or otherwise, do we just hear of cases? We just hear Chimamanda complains, the man who in Ajangbadi, whose twins died, complains, the woman in Kano whose family is crying, keeps crying. It doesn't look like there's enough of cases of people who have been caught napping and accused of negligence. It doesn't look like we see them being held accountable for their actions. So, and Doc, I want to, concede to you when you talked about Nigerian doctors being some of the greatest in the world. That is a fact. Go to anywhere and then you see them. But I am talking about those who have been accused of carelessness, accused of ignorance, accused of lack of professionalism. Some of them are caught sleeping on duty, exhaustion, arrogance, laziness, poor assessment of medical cases arising from their limitation in medical skills. How does the system hold such professionals accountable?
Thank you again for this question. You see, when we talk about sanitizing medical practice in Nigeria, you're looking at three key areas. One, the legal framework. How robust is the legal framework? I can assure you that the legal framework in Nigeria is quite robust. However, there's always room for improvement. So we may need to refine some of the laws, update some of the laws to become more comprehensive so as to allow little or no escape from the law. That is one, the legal framework. The next thing is the institutional framework, which we have mentioned in passing: the Medical and Dental Council, the court, the law enforcement agents, the press, the lawyers themselves, the patients themselves, the institutional mechanism. The third is the enforcement mechanism. How are the procedures prescribed for these laws and for these institutions? How strictly do we adhere to them? So having mentioned those ones, the next thing is this: why are we not having enough litigations? Let's identify the challenges against litigating these matters and getting court judgment, court pronouncements that will be a deterrent for further infractions. One is poverty. How many patient relatives can pay for a lawyer, can pay for court filing fees, can endure attending courts for several sessions that may range up to years? So poverty and financial challenge is a problem. Access to justice. Access to justice has two legs. We mentioned financial access. Well, there's also physical access. How many people in my village can have access, physical access to courts? How many courts do we have in the country? How many do we have in the rural areas? So physical access, financial access, access to justice is a problem. Thirdly, judicial activism. We all know that the wheel of justice rolls slowly. But you see, with judicial activism, the judges can take it upon themselves to see that medical negligence, medical malpractice, medical error cases are fast forwarded for the victims to get justice as early as possible. But you remember, there are processes, there are stages, there are steps in the judicial process. So we can't rush some of those steps. But with judicial activism, we can do better. Fourthly, awareness. How many people are aware that there are laws, there are ethics, there are rules, there are codes that guide health workforce in our hospitals? How many of them know that these things exist? How many patients are aware? How many doctors are aware of the legal provisions? How many nurses are aware of them? How many lawyers are aware that they can really seek and get justice for people? Then, fifthly, and very importantly, are religious and cultural biases.
I was waiting for that.
Yeah, we have a general belief that when somebody passes on, or when somebody suffers a complication from medical treatment, say that's how God wants it. Do you understand? It's both cultural and religious. Leave it for God. Do you understand? God will do justice and all those things. So many people, even even when they identify that they've been wrongly treated in hospitals, will still leave it for God and not seek justice. Because seeking justice is not justice for you alone, it's justice for the society and justice for the system. And you're helping to refine and improve the system when we have a system that is based on laws, on regulations, on ethics, on rules. So these are some of the issues. And then, of course, don't forget the issue of intimidation. Some patients are intimidated that if you go to court, we're not going to treat you again, or other doctors won't take care of you again, and all those. Intimidation is a problem. But intimidation comes from ignorance. Because if you're going to court, you're not going to court because you don't like the doctor or because you don't like the hospital. But you're going to the court to enforce the rights that has been given to you by the Constitution, by the laws of the country. You're going to enforce those rights. Most of them are really fundamental rights in our Constitution, or what people generally consider as human rights. But not many people understand why they have to enforce their rights in such cases that when they suffer injuries from medical negligence, medical malpractice, and medical errors.
Doc, I used to, oh, fantastic, you're there. I was wondering because I think I thought I had assumed I lost you there for a minute. I hear you and I hear you loud and clear. And in addition to that, I like how you've unbundled, how you've laid out this point from point 1 to, I think, point 5. And that's that's exactly why we're here. In addition to that, there's something else I think I would like for you to elucidate on, and that's how careful we need to be, even on this matter right now. In an attempt to be proactive in sanctioning those we think might be involved. And I'm talking about medical personnel now, and not just medical personnel, in sanctioning them, those responsible for negligence or, indicted for negligence. I think we may need to be careful, especially with regards to I think the word is circumspect. Yeah, we need to be circumspect in our sanctions digital. Otherwise, we may just develop a system where medical professionals eagerly resort to this self-preservation mindset in order to avoid stressful litigations or, litigations, as it were. How then do we balance proactiveness and circumspectness in ensuring standardization, in ensuring that, look, yes, we punish those that deserve to be punished. Yes, we hold them to account, but still, we do not create a situation that evolves into that self-preservation mindset for medical personnel, because they still have to venture sometimes and try. How do you explain that? How do we get or create that balance?
I like the last few words you used, that medical practitioners in Nigeria sometimes venture. We have
but with good reasons.
Yes, we have very serious resource gaps. We have equipment challenges in Nigeria. Most Nigerian doctors work in very difficult circumstances, not only because of extended work hours, but the tools, the materials they need to work with. In very many instances, sadly, they are non-existent or they are obsolete. So the Nigerian doctor needs so much praise and encouragement. I am happy that the government, under the current coordinating Minister of Health and Social Welfare, they are beginning to vote money to the right places. They are beginning to release the money as contained in National Health Act for emergency services.
And that's
they are beginning to enforce.
That's the 1% contribution from the Consolidated Revenue Fund.
Revenue Fund, yes. That's 1% contribution as provided in the National Health Act. So the current minister is doing a lot. But you see, the system has very critical challenges. So people are not really seeing what he is doing, but he is doing a lot. So we need to address these structural deficiencies. And while addressing them, we'll be addressing attitude of the health workers. Attitude is so important. And while addressing the attitude, we can now bring up the issue of accountability. So these are all part of the what we need to do. But to go to your specific question on
Balancing.
not to overflog the issues, yes, it brings to mind the kind of practice they have in the United States. What they have in the United States of America is what we call defensive practice. The payouts on medical law cases in the US is the highest payday for lawyers in the US. And therefore, you cannot practice in the US without having a robust insurance to protect any possible litigation, to protect you from any possible litigation. Most American doctors practice what you call defensive practice because they tend to defend themselves before anything happens so that they won't fall victim to medical law litigations. Do we want that in Nigeria? No. We're already challenged by equipment. If doctors start defensive practice, I can assure you that more patients will die. Remember that apart from life-threatening emergencies, a doctor is also entitled to reject patients that are elective patients. So when we start defensive practice in Nigeria, it's going to be disastrous for our patients. Therefore, we just need to enforce the law. We don't need to overheat the polity. We don't need to overflog the issues. We don't need to begin to look at all the I's, are all the I's dotted or are all the T's crossed when doctors are practicing their profession. But we still need to enforce the law and ensure accountability and ensure that due process is followed to achieve the best possible care for our Nigerian patients and those non-Nigerians who are living in Nigeria.
Doc, I will take that as your final word because I was just going to ask you that in ensuring patient safety, how do we then begin to tick some of these? When you talked about dotting the I's and ticking and crossing the T's, I assumed you were talking about maybe, for instance, surgical safety checklist and all of that, and that we need to, ensure that protocol, some of these laid out protocols are followed. But just by way of rounding off this conversation, what do you think should be our priority first and foremost, as we, begin to critically look at these issues of, basic emergency response and surgical safety checklist, like I just said, whether in public or private hospital practice in Nigeria, as it is now, right now, with all of what we have on our hands right now. Final words, just a few seconds, and we'll wrap up.
We need to upgrade our health facilities.
Okay.
Thorough upgrade. 2, we need to pay doctors in Nigeria more to boost their morale and retain our human resource in healthcare. Pay doctors, nurses, lab scientists, pharmacists, pay them better to retain the people we have trained, who have high caliber, high quality. We need to enforce the laws, the rules, and the regulations.
True.
And we need to work on attitudinal changes for health workers.
Fantastic. And these are some of the points you've laid out and explained expansively in the course of our conversation. Dr. Chijioke Obalum, distinguished medical and legal expert, associate professor of orthopedics. Are you still associate, doc, or you're now professor of orthopedics and traumatology?
Very soon, I'll have my full chair and be a full professor.
Fantastic.
I'm an associate professor of orthopedic surgery and a senior lecturer in law.
Fantastic. We're looking forward to your full professorship. Thank you so much. And of course, former chairman, Medical Advisory Committee, State House Medical Center. I'd like to thank you so much, Doc, for coming on the program. Hopefully, we have another opportunity to bring you on and perhaps explore other perspectives to this issue, or maybe we'll talk about something completely different, but of course, within the realm of medicine and legal practice as well. Thank you so much for coming on our program.
Thank you, Namdo Odipo, and thank you, NTA.
Elizabeth Omoru is up next. She will be talking about youth and skills development, of course, youth inclusion in policy governance in Nigeria. That conversation comes up next.
The National Directorate of Employment, NDE, is mandated to design and implement programs to address mass unemployment. Now it's a new year. What are the prospects like? Silas Agara, Director General, National Directorate of Employment, will speak to us on how the Directorate has fared in meeting the mandate of the renewed Hope Agenda in 2025. Thank you so much for joining us on Insights.
Thank you very much. Insight, wishing all Nigerians a prosperous new year.
Okay, thank you so much, sir. Now let's begin. What's the mandate like for NDE? Let's hear from you before we delve into our main focus.
Yes, like you aptly introducing from the beginning, our is to design and implement programs that is geared towards addressing the unemployment challenges in the country and having statistics of our youth that are looking for meaningful employment engagement. And I'm very happy to let you know that we have been able to address some of these challenges. In the year 2025, we flagged off a Renew Hope employment initiative, and we've been able to train Nigerians from all the 36 states of the country, young Nigerians from all the 36 states of the country. And that program was successfully concluded in the second week of December. Those that are not captured under the skill funds will be paid under the capital funds as soon as the capital funds is made available to the agency. While for the settlement package and the startup package, hopefully in the first quarter of the year, by January, we should be able to disburse the resettlement package to all the trained beneficiaries. Over 40,000 of them will be rightly addressed by in the beginning of the year 2026.
Okay. Now, still on meeting the targets, you talked about meeting 40,000 Nigerian youths, but let's talk about those at the grassroots. How have you been able to reach them, meet them, impact their lives through this initiative?
Yes, our program is designed for all Nigerian youth, irrespective of where you domicile, in the urban areas, the rural area. Our program is meant to address all these youth, and we reach out to them through the portal system. Our portal has been made open, and those that readily applied through the portal system is from the portal system that will pick the eligible qualified candidate that should be trained, depending on the criteria. We look at certain benchmark. Some of them have applied to be trained, but we look at their income, what income is accruable to them at the end of every month. For some, when we look at those income, we not look, they are not eligible. They have passed the benchmark of those to be trained, and those with lower income or those not any income at all. Those are the youth that we target and ensure that they are trained. So our portal is, of course, open, readily accessible by all Nigerian youth, irrespective of where they are domiciled. As long as you have an internet facility, you can link up, and so it's readily available. No matter how remote the areas are, you will agree with me that internet facility is the coverage area. We won't say it's 100%, but of course, most part of Nigeria is covered when it comes to accessibility, and most of them have registered on our data bank. As we speak, we have over 1 million Nigerians, youth, that have registered and looking forward to be trained. And whenever the opportunity comes, we'll go back to our data bank and select those youth, irrespective of where they are staying. Is it the urban area or the rural areas? We'll look at those that are qualified to be trained, and we'll train. And we ensure that it's equitably distributed across the country. In the first program that we ran, and we had a minimum of 10 youth per electoral ward, a minimum of 10 per electoral ward, and the first phase of the Renew Hope initiative. This second part of the program is a continuation of what we did in the first phase. And I can assure you, we are hoping to run a new program. We are going to have 2 programs in 2026.
Let's talk about a particular segment of the population, persons living with disabilities. How have you been able to penetrate this category of people?
Yes, that is very interesting because in the first phase of the program that we ran, we had a special quota, a special allocation for persons with disability, which again we made available to the commission itself. It was the commission that was able to reach out to members of that community and got us eligible candidates to be trained. This time around, we were able to have a different training outside the main training for persons with disability. We had a very interesting conversation, meeting with the officials of the body, and they were able to recommend per state certain numbers of persons that we train. We have trained over 1,000 of them at different stages of the program, and we're working towards having their resettlement package, their startup packs, made available to them. Hopefully, in the early part of in the first quarter of the year, 2026, we should be able to address that aspect of their resettlement package because it's captured in the capital aspect of the budget. And we have a very good working relationship with persons with disability. Our offices are readily accessible by them. Whenever they have challenges, they come forward to discuss with us, and there's no discrimination at all.
Okay.
We ensure that persons with disability are readily captured. We ensure that people from the rural areas are given priority, mostly the women from the rural area. Because if you look at statistics, if you look at research, women from the rural areas are more deprived, more neglected when it comes to programs that are run by certain agencies of government. And we ensure that our focal officers in all the local government, because we have a focal persons in all the local government of the Federation, our focal officers are directed to reach out to them. And we have a very special relationship with them because they have been adequately addressed, trained by NDE, and the feedback mechanism is quite encouraging from the rural communities.
Okay, now let's talk about challenges. How have you been, since you came on board, how have you been able to address some of the challenges confronting some of the schemes, some of these initiatives to touch lives of Nigerians?
Yes, there's no segment of this country that don't have challenges. There's no agency of government that don't have challenges. But we confront those challenges headlong as we work towards making the place more comfortable for all. First is the working environment, because without a good working environment, whatever program that is designed, whatever program you are designing for those you intend to capture will not certainly fly. The working environment was quite appalling. I don't know if you have visited the former headquarters somewhere in Zone 1, Wuse Zone 1. ND was supposed to provide hope to young Nigerians. But the moment you come to our corporate headquarters, your hope gets dashed because of the working environment and the working conditions there. So the first thing we had to do, and that I must appreciate Mr. President for the backing, for making funds available, for supporting the programs of NDE. And today, as we speak, we're operating from our new corporate headquarters. Our state offices, we've tried to reach out to them by way of providing hardwares to them, computer system, because all our structures, all our operations now is automated. The portal system is linked up to all the state offices. And so they are online seeing what is happening at the headquarters, where the recruitment of beneficiaries is being, they are recruited directly from the state. And so without sufficient working facilities, it will be difficult for them to operate. Before now, most of them were working with their laptops. There was virtually no system available for them. But today, there's no state office you go to that you don't have the software and hardware are made available to them. Printers, photocopiers, laptops and desktops have been made available to them to work. And so it makes their work more efficient now.
And easier.
Yeah, and they are happy with it. They can work throughout the day. They work late into the night and ensure that when we are recruiting those that are supposed to benefit from the program, they are in their various offices doing it, not working with their system.
Okay.
And so we are happy. We're not there yet, but I'm hoping that by 2026, when the new budget will be passed into law, some of this deficit will be addressed.
And now, let me come in there. You are a sports administrator. How have you been able to bring your expertise to bear to ensure that you drive the Renewed Hope agenda so that the youths can fully benefit?
Yes, the two, for me, my sport background have given me an edge in addressing what I'm doing in NDE. You know, in sport, you work with young minds. You work with young Nigerians. I've been president of various federations. I've worked in various federations. I'm currently an executive member of the Nigerian Football Federation. I've been president of, vice president of cycling, president of karate. And it has given me the opportunity to work with young Nigerians out there. It's only the young minds that are in sport. And most of these young men in sport are looking for opportunities, a platform to excel. Challenges of Nigerian youth. And that have given me an edge coming to ND. ND is meant to work with young Nigerians, young unemployed Nigerians. And so the two, for me, I have an advantage, I have an edge, and it has helped me to reach out to these young Nigerians that are looking for opportunities. I encourage them, those that are in sports, are looking for the platform, I encourage them to come into ND and have an opportunity where they can have something, a second option in life. Because sport is a talent, and those talents have an expiry period. When they are over 30, they begin to decline. No matter what, no matter the strength, the energy you have, you begin to decline. You can see, even for footballers, when they are above 30, they begin to depreciate, and their value in the market goes down. And so with other sports. And so they must have a second option. And this NDA gives them a second option because they have a trade. They have something they can fall back to. If they don't make it in sport, they have a second option. And that's the way to encourage them. And they're happy. Most of these young men I've worked with in sports, today have been trained in various skills in NDE. And that's the way to go. And I believe that I thank God for giving me that the platform at ND. I thank Mr. President for finding me worthy to be appointed to address these challenges. And it has given me a more insight into the challenges of Nigerian youth.
That's good to know. Now, two of my final questions are these. How do you evaluate and monitor skills, impact of skills? How do you evaluate and monitor them?
We have a feedback mechanism. We have our field officers. We have our MIE department sufficiently equipped. And the MIE department are domiciled in all the states. And those that we have trained and impacted, MIE officers go around the states to monitor them and to have a feedback mechanism on what they are doing. Some of them have been given certain loans, facilities, and certain startup packs and where they are having challenges, our MIE officers report back to us.
Okay.
For some, we might need to even upgrade the loan facilities given to them because of the peculiarities of the market. It's possible at a time of disbursing these facilities, things have changed. And so our MIE officers are able to assess and get back to us. And some that are doing fairly well in the public space, when we are going for fairs, trade fairs, we pull all our trade beneficiaries from all the states. For instance, if you have the last Lagos Trade Fair, we have to pull our beneficiaries, those that are doing very well in certain fields, and give them the opportunity to participate in those trade fairs. That's just one aspect of a feedback mechanism. And likewise, other trade fairs that we organize by states, by regional structures, we ensure that they are doing they feature prominently in those fairs. And we take time to visit their stores, their shops, to see what they are doing, to assess. Those that are having challenges with NAFDAC in terms of registration of their product, we ensure that we are there for them. Those that have challenges with standard organizations of Nigeria and other government agencies that they need certain level of approvals, we are always there for them to support them. And so that level of collaboration does not just stop after the training, it continues. We have a long-lasting relationship with our beneficiaries. Our MIE structure works in such a way that those that we have trained and are doing very well, we encourage them to train others in their own community. And we patronize them. When we need master skilled trainers, we fall back to them and they come in to train other young ones and encourage them. Look, they tell them, look, I was on the other side just like you, but today I'm on this side, providing this training to you, and I'm better off today. And so these are the kind of collaboration, feedback mechanism that we have with our structures. It's a relationship that is not just time bound, but it's there.
It's there.
It's there for as long as we are alive on this Mother Earth. We'll continue to sustain that relationship, and we hope that whatever it is, 2026, I must assure you that it's going to be more productive, more useful to ND.
Now, talking about 2026, what are your prospects? That's my last question.
Yeah. You know, most programs we are doing, somehow I find myself being cornered by NTA to to let the cat out of the bag. That was what happened in our first and second phase of it. But in 2026, we'll have a new program that we have designed. And we are having a collaboration with, we have 12 river basins in this country. And these 12 river basins are spread all over the country. And they have, in terms of accessibility, access to land and other facilities is made available to these river basins. Some of this land are uncultivated, unutilized. And we're having a collaboration with them, and we're pulling a minimum of 1,000 youth per state to work, to encourage them to go back to farm, different aspects of farming. Fishery, animal production, aquaculture, vegetable and other mode of farming. We're encouraging to go back to farm, and we're picking a minimum of 1,000 youth per state. We're working on a collaboration with the river basins we'll clear those land for them, get them all the farming inputs, farming implements that they need. And we're having a handshake with the National State Council. The National State Council is part of the collaboration. So it's a tripartite arrangement.
Director General, National Directorate of Employment, we want to thank you so much for joining us on Insight, and we wish you all the best in the new year. Thank you very much.
Always a pleasure being here. I thank you, NTA.
And that's it on this episode of Insight. Do join us same time next week for more on the program. My name is Nnamdi Odipo.
And I'm Elizabeth Omori. We'll see you next week. Bye for now.